Good morning, good afternoon, and good evening, everybody. Welcome to today's webinar on the burden, consequences, and cost of Shigella diarrhea in young children and implications for Shigella vaccines. Thank you for joining us from around the globe. My name is Dr. Patricia Pavlanak, and I'll be guiding you through today's session. Before we begin, I want to remind you all of a few housekeeping items. The session is being recorded and will be shared afterward. Attendees are muted upon entry to minimize background noise. Please use the Q&A panel at the bottom of your Zoom screen to submit questions at any time, and use the chat for comments and technical support. If you experience any issues, please send a direct message to Zoom hosts in the chat. Before I introduce you to today's speakers, I'd like to give you a little background on the EFGH consortium. This slide shows a summary of where the EFGH study has taken place in purple and identifies the coordinating institutions within the consortium. Those are in white. The consortium was importantly funded by the Gates Foundation. The EFGH consortium was led by the PIs listed here, representing investigators with rich expertise in pediatric diarrheal diseases and clinical trials from around the world. Our consortium was designed with 5 key principles. First, shared scientific decision-making between coordinating and implementing institutions. Centralized, streamlined communication to ensure all stakeholders are involved and informed of processes. Equitable authorship and publication opportunities across stage and location of investigator. Rapid, easy access to generated data for all partners, and investigators be supported to present at conferences, lead sub-analyses, and leverage the EFGH platform for additional funding. Here are some tangible examples of how we operationalized our principles. For example, a funded planning phase, including representatives from all EFGH sites and coordinating bodies, enabled co-development of study protocols, CRFs, and SOPs through Zoom protocol working groups. The Rising Star Award program and manuscript writing cohort enabled early career investigators from within the consortium to lead nested studies and secondary data analyses in parallel with the funded EFGH parent study. Today, we'll hear from representatives from all 7 sites across the EFGH consortium who will present recent findings and lessons learned. Each presentation will be about 8 minutes, followed by ample time at the end of all presentations for questions and answers. To begin, I'll share some brief background on each presenter. Dr. Jen Kornick, representing Malawi, is a senior lecturer in the Institute of Infection, Veterinary, and Ecological Sciences at the University of Liverpool. Dr. Francesca Schiaffino with Prisma Peru is an associate professor of veterinary medicine and animal science at Universidad Peruana Cayetano Heredia and a visiting scholar in the Division of Infectious Diseases and International Health at the University of Virginia. Mr. Henry Baji, an investigator from the Gambia team, is a microbiologist at the Medical Research Council Unit, the Gambia, at the London School of Hygiene and Tropical Medicine. Dr. Adama Mambi Kaita, representing the Mali site, is head of the epidemiology department at the Center for Vaccine Development in Mali. Dr. Sonia Qureshi, coming from the Pakistan site, is an associate professor of pediatric infectious diseases in the Department of Pediatrics and Child Health at the Aga Khan University Hospital, Pakistan. Dr. Farhana Khanam, representing the Bangladesh site, is a senior scientist with the Mucosal Immunology and Vaccinology Unit, Infectious Diseases Division within the International Center for Diarrheal Disease Research, Bangladesh. And Mr. Billy Ogwell is a research scientist within the Center for Global Health Research at the Kenya Medical Research Institute. Welcome again, and let's begin with our first presentation.
So thanks, Patty. Good morning, good afternoon. My name's Jen Cornick, and I'm going to move on to cover the rationale, brief study design, and patient populations of the EFGH study. So Shigella is a major cause of diarrhea in children under 5. It was responsible for over 80,000 deaths in 2021. Beyond diarrheal disease, infection leads to stunting, reduced effectiveness of routine childhood vaccines, and lifelong health impacts. Treatment is increasingly difficult as rising antibiotic resistance severely limits available therapeutic options. So, as this image depicts, lower middle income settings shoulder the heaviest burden of disease. Vaccines offer a critical opportunity to reduce the global burden of shigellosis and the growing threat of AMR, but there's no licensed vaccine currently available for human use against Shigella. Multiple Shigella vaccine candidates have demonstrated safety and immunogenicity in early phase clinical trials, but progression to licensure will require well-designed phase 2 and 3 efficacy trials conducted in target populations, so young children living in LMIC countries where the disease burden is highest. There are, however, several considerations that need to be made when we design Shigella vaccine trials. So, what is the desired age where all doses must be completed? And how does this fit within existing API schedules? Which primary clinical outcome definition should a trial use? Moderate to severe diarrhea, medically attended diarrhea, or all diarrhea? What would the primary microbiological outcome be? Culture confirmed shigellosis, molecularly diagnosed shigellosis via qPCR? And would you look at all Shigella within a vaccine trial, or would you just target the species and serotypes included in the vaccine you're trialing? Finally, you'd ideally base any sample size on the incidence of Shigella in your target population where the eventual trial will take place. So it's really addressing these questions that's driven the rationale of the EFGH study. So in brief, EFGH had 2 main aims. Firstly, to generate updated country-specific data on the incidence and consequences of shigellosis to appropriately power future vaccine trials and to maximise likelihood of uptake into API. And secondly, to prepare sites via training, capacity building, and infrastructure development to rapidly implement a future vaccine trial. EFGH also had 6 secondary aims to further inform future vaccine trials and uptake, and these were from describing AMR prevalence to quantifying the cost of shigellosis to families. And I'm not going to list all of these in detail, but just note they'll be covered by subsequent speakers in today's webinar. I'm going to briefly explain the methods, but please note that the methodology will be explained in further details in subsequent talks. And also, if you're interested, full details for the methods have been published in a supplement in Open Forum of Infectious Diseases, and this is accessible via the QR code on the screen. So EFGH was a hybrid surveillance study, and it consisted of a facility-based diarrhea case surveillance study. Over a 24-month period, we aimed to enrol 9,800 children aged 6 to 35 months with medically attended diarrhea who presented to EFGH recruitment facilities in our 7 study countries. And follow-up was conducted at 4 weeks, 3 months, and unscheduled sick visits. At enrollment, rectal swabs and whole stool were collected, and a child was considered to have Shigella attributable diarrhea if Shigella was detected by culture and or by qPCR using the Tachman array card. And we used a stringent CT of less than 29.5, and this CT was based on robust data from previous large-scale diarrhea surveillance studies. Dried blood spots were collected at enrolment and week 4 for an immune response substudy. Whole stool samples were also collected for a diagnostic substudy on inflammatory biomarkers, and we also collected information on costing, sociodemographics, and prior healthcare seeking. As I said, this was a hybrid surveillance study, so we also, simultaneously to accurately ascertain Shigella incidence, conducted a population enumeration and healthcare utilisation survey, and this was performed within the catchment area of the EFGH recruitment facilities. Sites all started at different time points, but all enrolled for no longer than 24 months. The first participant was enrolled in June 2022, the last in August 2024. And the last follow-up visit was conducted in December 2024. During this time, across all of the sites, over 125,000 children presented to care at the EFGH study facilities. 29,355 were screened and 9,476 were enrolled into the diarrhea case surveillance study. This next table shows the characteristics of the participants enrolled into the diarrhea case surveillance component of EFGH. Just to note, less than half were female, and the median age was 14 months. 21% had sought some form of care before presenting to the recruitment facility. 23.7% were stunted, 16.9% had moderate or severe wasting, and 21.7% were moderately or severely underweight. This next slide shows how many children were followed up from those enrolled. Of the 9,476 participants, a high number, 9,061, returned for their 3-month follow-up visit. So we had a good retention rate. And this is my final slide, and it shows the characteristics of the children included in the contemporaneous healthcare utilisation survey. Just to note, through the hard work of our numerator teams, we were able to enumerate over 1 million individuals within the catchment area of the study facilities. Of these, 54,609 were children aged 6 to 35 months, and 8.9% had experienced diarrhea in the last 2 weeks. And with that, I'd like to pass over to our next speaker.
Perfect. Thank you, Dr. Kornick. Now we will be talking about Shigella prevalence and incidence rate by culture and qPCR. Let's briefly recap the incidence definitions in the EFGH study. The primary outcome in this analysis is the incidence of Shigella attributed medically attended diarrhea, defined as the estimated number of Shigella medically attended diarrhea cases in each of the EFGH sites' catchment area per 100 child years at risk. At-risk time was calculated using the EFGH population enumeration study, briefly described by Dr. Kornick. The adjusted incidence was estimated as the number of confirmed Shigella diarrhea cases at health facilities in the catchment area per 100 child years at risk, accounting for the proportion of children who sought care and were enrolled in EFGH, as well as a proportion of diarrhea cases with similar severity to enrolled cases who sought care using a propensity to seek care model. Now let's start with the results. Between June of 2022 and August of 2024, a total of 9,476 participants were enrolled across the 7 sites previously described. Among the enrolled children, Shigella prevalence by culture was 9.3%, with 884 unique isolates obtained from 881 participants. Shigella prevalence increased to 20% when assessed by qPCR, with 1,917 unique detections of Shigella at attributable levels from 1,870 enrolled participants. Of these, 52.9% of participants with Shigella attributed by qPCR result did not have a Shigella isolate by culture. Across all sites, Shigella prevalence was consistently higher by qPCR than by culture. Shigella flexneri and Shigella sonii were the two most prevalent serogroups at all sites and across the two diagnostic methods, comprising 56% and 29% of isolates, respectively. The most common Shigella flexneri subserotype by culture was Shigella flexneri 2A with 32.4%, followed by Shigella flexneri 6, Shigella flexneri 4A, and Shigella flexneri 3A. However, there was variation by site, with Shigella flexneri 2A being the leading subserotype in 3 sites, including Bangladesh, Pakistan, and Peru. Shigella flexneri 6 being the leading subserotype in Kenya, Mali, and the Gambia, and Shigella flexneri 4A being the leading subserotype in Malawi. These results highlight the importance of monitoring for serotype replacement following introduction of a conjugate Shigella vaccine. Among qPCR-attributed Shigella cases, flexneri and sonii were the most common serogroups at 39% and 40% respectively. Notably, we did not use probes for Shigella boydii and Shigella dysenteriae. The leading flexneri subserotype by qPCR included Shigella flexneri 2A, Shigella flexneri 6, matching culture results, yet by qPCR, Shigella flexneri 1B and Shigella flexneri 3A were also dominant, and less so 4A. Now, moving into the incidence rate, the adjusted incidence of Shigella medically attended diarrhea was 6.3 per 100 child years by culture and 14.65 per 100 child years by qPCR. Incidence rate varied by site, ranging from 2.7 per 100 child years in Malawi to 11.7 per 100 child years in Peru by culture, and 3.5 per 100 child years in Malawi to 26.9 in the Gambia by qPCR. These slides show the adjusted incidence rate by age group. The pattern of age-specific incidence rates were similar for culture and qPCR, with similar incidence rates in the 6 to 8 months old and the 24 to 35 months old, and gradual increase from the 9 to 17 months old, with a peak in the 18 to 23-month-old group. The observation that Shigella diarrhea incidence peaks in the second year of life is consistent with other studies that use comparable methodologies such as GEMS and VIDA. Although lower in the 6 to 8 months old, the adjusted incidence of Shigella diarrhea was non-negligible in this age group, and the incidence rates in 9 to 11-month-old exceeded those in the 24 to 35 months old. Given severity is highest in the youngest children, as is risk of death and growth faltering, a Shigella vaccine achieving early and sustained protection is likely to prevent the most morbidity and mortality attributed to Shigella. Based on the results presented, as well as the formulations of 2 leading quadrivalent vaccine candidates, these vaccines would prevent between 58.4 and 63.6 culture-proven Shigella cases, and between 41.5 and 44.1 qPCR diagnosed cases if we assume no cross-protection. Assuming some protection across flexneri subserotypes, not containing the vaccine, but with shared O antigen structure, the 2 leading quadrivalent vaccines would prevent between 69 and 74.5 of cases confirmed by culture, and between 41.5 and 52% of qPCR diagnosed cases. In an eventual phase 3 vaccine trial, the incidence rate of moderate or severe diarrhea attributed to Shigella strains containing the vaccine would likely be the primary endpoint. This slide shows the site-specific incidence rate, and as an example for a quadrivalent vaccine with 2 possible moderate to severe diarrhea definitions, the incidence rates are about 2 and 3% per 100 child years by culture and qPCR respectively, with of course some site variability. Finally, this slide presents other qPCR attributable pathogens detected among Shigella diarrhea cases. Among culture-confirmed cases, 23% had another enteric pathogen detected at a qPCR attributable level. Among qPCR-confirmed cases, 31 had another pathogen. The most commonly identified co-pathogens were ST-ETEC, rotavirus, and cryptosporidium. When we subset the diarrhea to more severe forms of diarrhea, we see a very similar distribution of co-pathogens, with rotavirus and STE-TEC remaining at the top. What I'm not showing in this slide is the site-specific burden of co-pathogens, which varied by site, with co-pathogens present in almost 17% of Shigella cases in Peru, yet in 48.3% of Shigella cases in Bangladesh. So to conclude, the EFGH study confirmed high Shigella burden among children living in low and middle income countries, and that the incidence of Shigella peaks in the second year of life, but remains common in 6 to 12-month-olds, possibly warranting complete vaccine protection before 12 months of age. Shigella sonnei, Shigella flexneri 2A, 3A, and either 6 or 1B contribute to about 60% of Shigella diarrhea cases. If there is cross-protection across certain Shigella flexneri subserotypes, as much as 75% of cases might be preventable with the introduction of a quadrivalent Shigella vaccine. As Shigella vaccine trials are designed, the question of how to deal with co-pathogens in primary endpoint definitions will need to be addressed. So now I will handle the presentation to our next speaker. Thank you.
Thank you, Dr. Francesca. My name is Henry Baji, and I'll be sharing about antimicrobial resistance in Shigella and implications for the future of diarrheal disease management. AMR is recognized as a global health challenge and one of the major threats to human health presently affecting all regions. In 2019 alone, AMR was associated with about 5 million deaths worldwide, and the highest burden was recorded in Western Sub-Saharan Africa with over 27 deaths per 100,000 people, highlighting the disproportionate impact on low and middle income regions. One of the most pressing issues with AMR is that it significantly limits treatment options, particularly in resource-constrained settings where alternative therapies are scarce. This makes AMR a critical health challenge that demands urgent action. The WHO recommends ciprofloxacin as the first-line antibiotic for treating Shigella infections, with azithromycin as an alternative for settings with high ciprofloxacin resistance. Second-line options include ceftriaxone, cefixime, and pivmeselinam. Trimethoprim is also listed in WHO guidelines as an alternative, but with clear specifications that it should only be used in settings with demonstrated susceptibility to this antibiotic. Moving on to our methods. Antimicrobial susceptibility testing was performed using the Kabibauer disk diffusion method as previously outlined. Susceptibility results were interpreted using the Clinical and Laboratory Standards Institute guidelines. The antibiotics tested included ampicillin, azithromycin, ceftriaxone, ciprofloxacin, nalidixic acid, pivmeselinam, and trimethoprim. For azithromycin, results that were ambiguous or had inhibition zones that were difficult to measure, the minimum inhibitory concentration was determined to ensure accurate interpretation. Moving on to our results. A total of over 9,000 children with medically attended diarrhea were enrolled in this study, and among them, 884 yielded Shigella by culture, accounting for 9.3% of participants. AST was performed on all 884 Shigella isolates recovered from the 7 EFGH study sites. The figure shows AMR patterns across the sites. Overall, we observed high resistance to ampicillin and trimethoprim across all the sites. We also observed clear geographical differences in resistance patterns. In both African and South American sites, resistance to trimethoprim was the highest. However, this was not the case in Asia. For instance, in Bangladesh, the highest resistance was observed to nalidixic acid, along with a high resistance to ceftriaxone, while in Pakistan, ampicillin showed the highest resistance, with high resistance to ciprofloxacin also observed. This heat map presents similar information to that shown in the previous slide, but in a different way. It shows resistance in absolute numbers and the proportions they represent across the various sites. The darker the color, the greater the number of resistant isolates and the higher the proportion of resistance. Overall, AMR was more common in Bangladesh and Pakistan. When we looked at multi-drug resistance, defined as non-susceptibility to 3 or more antibiotics, this was moderate at the African and South American sites, but high in the Asian sites. Extensively drug resistant, defined as non-susceptibility to azithromycin, ciprofloxacin, ceftriaxone, trimethoprim, and ampicillin. This was absent in the African sites, but present in Peru and the Asian sites. Whereas resistance to all WHO recommended antibiotics, defined in our study as non-susceptibility to azithromycin, ciprofloxacin, and ceftriaxone. This was either absent or low in the African sites and Peru, but present in the Asian sites. These heat maps illustrate the antibiotic resistance among Shigella isolates by site and species. Shigella flexneri and Shigella suni were the most common species, accounting for about 85% of the isolates. AMR appeared to be highest in Shigella suni species, particularly isolates from Bangladesh and Pakistan. Ampicillin and trimethoprim resistance was particularly common among Shigella flexneri isolates, nearly universally across sites. In conclusion, our study highlights several key findings. First, our study showed a high burden of AMR among Shigella isolates causing diarrheal diseases. Second, there is clear evidence of emerging resistance to WHO-recommended antibiotics, particularly across Asia. Third, there is also an increasing proportion of Shigella isolates exhibited intermediate resistance to ciprofloxacin, raising concerns about the declining efficacy of this important first-line antibiotic. Fourth, while multi-drug resistant and extensively drug-resistant strains were detected only at Asian sites, their presence raises concern about potential future emergence in Africa and South or Latin America. Fifth, our findings underscore a substantial burden of resistance to WHO-recommended treatment options, with the greatest impact observed in Asia. Taken together, our findings emphasize the urgent need for strengthened antibiotic stewardship and the implementation of preventive strategies, most notably the development and deployment of effective vaccines to address the growing global challenge of AMR, particularly in Shigella, which is a leading cause of diarrheal disease. Thank you, and I'll now hand over to our next speaker.
Thank you, Henry. My name is Adama Mambi Keita, and I will be sharing data on the clinical presentation of Shigella and other leading pathogen. I will start with summarizing a few additional methods To add to the method already described by Jane, for pathogen other than Shigella, we also use quantitative PCR to detect enteric pathogen. Pathogen-specific cycle threshold cutoff based on likely attribution of diarrhea episode to the pathogen were established from James and Maridi study and used in EFGH. Signs and symptoms of diarrhea episode were captured at enrollment through a physical examination by study clinician and caregiver interview, during which a full clinical story was collected by a 14-day diarrhea jury and a physical examination and caregiver interview collected at a week 4 follow-up visit. The diarrhea jury card and memory aid, which were translated into local languages and sent home with caregiver to complete after completing the first day of the jury with a study team member. The study team then check in with the caregiver by phone or through home visit a few days after children return home from the enrollment visits to answer any question about the diarrhea jury and to encourage the completion. We had a good adherence to this 14 days jury, with 95% caregiver returning the jury, and of those that return, 91% having completed it. Now I will share some results. As Francesca showed, the proportion of Shigella with the proportion of children with Shigella detected at attributable level by PCR range from 10% in Malawi to nearly 30% in the Gambia. The detection of rotavirus at attributable level here, as you can see in the lighter green, was also high across EFGH countries, ranging from less than 5% in Peru to close to 30% in Bangladesh. We abstracted vaccination information from enrolled children and asked the caregiver if about the child vaccine story when the card is not available. And based on this information, you can see that rotavirus vaccine coverage among children enrolled in EFGH was quite high, ranging from 98% in the Gambia to 67% in Kenya. Bangladesh is the only EFGH country which has not yet introduced the rotavirus vaccine into the API schedule. The region coverage is particularly low is because there was a vaccine shortage during the study. ST-ETEC was less commonly identified at attributable level as compared to Shigella and rotavirus, albeit was more common than rotavirus in Pakistan and in the Gambia. Cryptosporidium was detected at attributable level in about 5% of the children enrolled in EFGH, although exceeding 10% in Mali and the Gambia. Adenovirus was the fifth most common attributable pathogen, ranging from 2 to 6% detection. In looking at the distribution of the top 5 pathogens by age group, we see that rotavirus is the most common, followed by Shigella in the age group 6 to 11 months old, whereas Shigella is the most common pathogen in the age group 12 to 23 months, and also the age group 24 to 35 months, followed by rotavirus and ST-ETEC. Looking at the clinical feature of each pathogen, and starting with Shigella here, we see that among the nearly 2,000 children with Shigella attributed diarrhea, fever and longer duration of diarrhea were present in nearly 75 and 50% respectively. Vomiting and dysentery or bloody stool were also relatively common feature in Shigella diarrhea. GEMS, which is the Global Enteric Multicenter Study, and GEMS 1A reported on clinical feature of Shigella in dysentery and watery diarrhea cases, and vomiting and severe dehydration were present in similar proportion of the cases. Among the 1,000 children with rotavirus attributable diarrhea, we see that fever and longer duration of diarrhea were similarly common, but vomiting was more common among the rotavirus case than Shigella cases, and hospitalization was similarly more common among children with rotavirus diarrhea. In looking at the over 3 etiology, we see that dysentery was particularly common in children with Shigella, and vomiting as well as hospitalization particularly common in children with rotavirus, and no over major clinical feature across the over pathogen. But this trend remained the same when we remove the subset of children who had more than one pathogen detected at an attributable level. In conclusion, Shigella was the leading cause of diarrhea at 5 of the 7 EFGH sites, following a close second only to rotavirus in 2 of the sites. Rota burden remained high, even in countries with high vaccine coverage. This pathogen, rotavirus, ST-ETEC, cryptosporidium, are important etiology in addition to Shigella. And while Shigella is second to rotavirus in the age group 6 to 11 months, it's by far the most common attributable pathogen in the age group 12 to 35 months old. Shigella clinical features include fever, longer duration of the diarrhea, vomiting and dysentery, albeit vomiting and hospitalization are more common with rotavirus attributable case. The detection of more than one leading pathogen at attributable level occur in several cases, most commonly in those with rotavirus and ST-ETEC. I'll stop here and hand it over to our next speaker. Thank you.
Thank you, Adama. Hi, everyone. I'm Dr. Sonia Qureshi from Pakistan, and I will be presenting the findings related to consequences of Shigella and other enteric pathogens among children with medically attended diarrhea. So why does Shigella matter for child health? Because beyond contributing to childhood mortality and morbidity, it is associated with longer duration of diarrhea and long-term health complications such as linear growth faltering. Simulation model estimate that effective prevention of Shigella diarrhea could avert 43 million stunting episodes, nearly 600,000 deaths, and $4.4 billion in healthcare costs over 20 years. We have historical examples of measles and BCG vaccines that showed strong indirect benefits in reducing childhood mortality and stunting. As Shigella vaccines are entering into phase 3 trials, strong evidence on Shigella's health consequences is important for policymakers in low-resource settings. We compared the outcomes of interest between each of the 5 most prevalent etiologies to those with no identified pathogen. For example, we compared the risk of hospitalization in kids with Shigella to kids with no detected pathogen. Etiologies were defined using a pathogen-specific etiology qPCR cycle threshold, and no pathogens was defined as the absence of all diogenic pathogens that were tested for at a cycle threshold cutoff of 35. We also stratified children with bacterial pathogens such as Shigella and ETEC by antibiotic use based on susceptibility profile. Outcomes included death that occurred at any time point during the follow-up due to any reason. Prolonged diarrhea was defined as an diarrhea episode that lasted for more than or equal to 7 days. Persistent diarrhea was defined as an episode that lasted for more than or equal to 14 days. Hospitalization was defined as an overnight stay in the hospital ward, and change in linear growth was defined as the mean difference in length or height for HZ score between enrollment and 3 months follow-up time point. So overall, we observed very few deaths in our surveillance cohort, and causes of death were determined by a panel of specialists with an expertise in the field of infectious diseases. The common reasons of deaths were septic or hypovolemic shock or electrolyte imbalance and associated illnesses such as malaria or pneumonia or anemia. Of the 20 deaths reported in the population during the study period, 5 had Shigella diarrhea, and you can see them here highlighted in blue. It is important to note that 4 of these 5 children were wasted and all of them were under 12 months of age. In addition to these 5 children, 2 additional cases shown in the darker blue here had Shigella diarrhea detected by qPCR, but not enough to be considered attributable. Regarding the diarrhea duration, the median duration of diarrhea among medically attended diarrhea cases was 4 days with interquartile range of 3 and 6. There was some variation by site, and notably, the distribution of duration at all sites is highly skewed, with several participants experiencing longer diarrhea duration. Prolonged diarrhea was observed in 20% of children, and persistent diarrhea was seen in nearly 2.4% of children. And at the country level, the proportion of persistent diarrhea was highest in Pakistan and lowest in Mali. So this figure is showing the relationship of individual pathogens with prolonged diarrhea. 26.8% of children with Shigella diarrhea had prolonged diarrhea, compared to 14.9% of children with no detected pathogen, demonstrating a 56% higher prevalence in children with Shigella. A similar association was also observed in treated or untreated Shigella cases compared to no detected pathogen. We also observed that in addition to Shigella, ETEC and Cryptosporidium were significantly associated with prolonged diarrhea. Regarding persistent diarrhea, 4% of children with Shigella developed persistent diarrhea. Shigella was the only pathogen found to be associated with diarrhea persistence, with a 66% higher prevalence compared to children with no identified pathogen. So when we look at the results for hospitalization, children with Shigella diarrhea were not found to be associated with the risk of hospitalization compared to children with no identified pathogen. However, children with rotavirus or Cryptosporidium had nearly 2.5 times the risk of being hospitalized compared to children with no detected pathogen. Children who presented with an untreated STE-type diarrhea had 3 times the risk of hospitalization compared to children with no detected pathogen. These graphs show the changes in the length or height for HZ score over the 3 months following medically attended diarrhea, within each country and also stratified by the age category. The greatest drop in the Z-score was observed in the youngest children aged 6 to 11 months, with a median loss of 0.56 in Z-score. The steepest declines were observed in Pakistan and Bangladesh. However, all the countries showed progressive linear growth faltering. Okay, when we explored the impact of Shigella diarrhea on the length or height for age Z-score in the 3-month following diarrhea presentation, we didn't find any overall association compared to children with no detected pathogen. However, we did find that children with Shigella who were not given antibiotics or who were treated with ineffective antibiotics had a minus 0.05 greater loss in the Z-score compared to children with no detected pathogen. This is a moderate finding but significant one. No other pathogen were found to have an association with linear growth faltering. So to summarize, Shigella is associated with prolonged and persisting diarrhea, which has implications for child nutrition, growth, and its transmission to other household and community members. In addition to Shigella, STE-TEC and Cryptosporidium are also associated with prolonged diarrhea but not persistent. And untreated Shigella cases are associated with poor linear growth that leads to stunting, and it is associated with long-term costly consequences. Lastly, rotavirus, untreated STE-TEC, and Cryptosporidium are found to be associated with higher risk of hospitalization. Thank you. Now I will pass on to our next speaker.
Hello everyone. My name is Farhana Khanum. On behalf of the Bangladesh team, I am presenting the findings of comparison between different severity definitions for a Shigella vaccine trial endpoint. We have conducted this study because using a validated definition of clinical severity in the primary endpoint is a critical aspect of the design of efficacy trials for Shigella vaccines. Existing diarrhea clinical severity definitions have been validated against different clinical endpoints and in a variety of contexts. However, none have been evaluated specifically among Shigella cases. EFGH collected detailed clinical information from all enrolled participants over the course of diarrheal disease, and it is well poised to conduct a head-to-head performance of severity definitions among children with Shigella infection. The study aimed to compare 6 severity definitions in their ability to predict the risk of death or hospitalization or linear growth faltering among cases of Shigella attributable medically attended diarrhea. The following text is an example of how vaccine efficacy can be defined in a trial. For example, vaccine efficacy against acute, moderate, or severe diarrhea defined by one of the following 6 severity definitions caused by Shigella strains contained within the vaccine. The definitions are James moderate to severe diarrhea modified by Sikari score or MVS score, MVS plus minus dysentery, Clark, Mallet, and Shigella mortality score. Some key definitions were considered in this analysis, including study population, which included children with Shigella attributable diarrhea. The exposure was diarrhea severity as measured by 6 severity definitions. Clinician observed and caregiver reported clinical information was used to calculate these 6 severity definitions. Some analyses were stratified by receipt of guideline recommended antibiotics because appropriate treatment can interfere with the relationship between diarrhea severity and the adverse outcomes. There are 2 outcomes in this analysis. First one is the linear growth faltering. Second one is death or hospitalization. Linear growth faltering defined as changes in length for age Z-score or height for age Z-score from enrollment to 3-month follow-up visit. death or hospitalization defined by either event occurring within 14 days of enrollment. This data was abstracted from hospital records or caregiver report. Clinical information obtained from enrolled participants was used to define 2 severity definitions and 4 numeric severity scores. The table on this slide and the next describes the details of all 6 severity definitions, and there are several indicators in all definitions. However, all indicators are not included in all definitions. For example, number of days of diarrhea was included in 4 out of 6 definitions. For this slide, the description is the same as I mentioned for the earlier one. Now I am presenting the findings of this analysis. This bar chart presents the proportion of Shigella cases with the moderate or severe diarrhea. With the moderate or severe diarrhea as measured by 6 severity definitions and by sites. There was variation by both severity definitions and site. For example, MBS plus minus dysentery and Malate identified higher proportion of children with moderate or severe diarrhea across all sites. For all definitions, Malawi and Mali had the lower proportion of children with moderate or severe diarrhea, whereas the highest proportion of children with moderate or severe diarrhea was seen in Peru. If we look at the Shigella mortality score, you can see for Malawi, the proportion was 1%, and for Mali, the proportion was 5%, but the highest proportion was like 52% for Peru. This forest plot describes the association using a linear regression between diarrhea severity and change in length for height from enrollment to 3-month follow-up among Shigella attributable diarrhea. Severity definitions were dichotomized and models were adjusted for different factors like date of enrollment and the duration of between a number of days from enrollment to 3-month follow-up visit. In this plot, the points plotted on the left of the dotted line presents a stronger negative association between diarrhea severity or severity scores and change in length for height from enrollment to 3-month follow-up. So the severity definitions with the points plotted on the left are more predictive of decrease in length for height z-score from enrollment to 3-month follow-up among Shigella attributable diarrhea. Then we focused on children who did not receive guideline appropriate antibiotics. And in this analysis, we found that there are 3 definitions like MBS plus minus dysentery and Malate score are associated with change in length for height, z-score from enrollment to 3-month follow-up among children who did not receive appropriate treatment. Clinical information obtained from enrolled participants was used to construct receiver operating characteristic curves for 4 continuous severity scores on the second outcome, that was death or hospitalization within 14 days from enrollment among children with Shigella attributable diarrhea. And we found that the Shigella mortality score had the highest area under the curve, that was 91.1%. For other score like MBS plus minus dysentery, Clark and Malate had similar areas under the curve. An important observation is that all definitions had the similar sensitivity in predicting death or hospitalization within 14 days of enrollment. So in conclusion, we can say that severity definitions varied in what proportion were classified as moderate or severe, which will have implications for vaccine trial sample size calculations. A less restrictive definitions, for example, MBS plus minus dysentery and Malate may be preferable to ensure the outcome is frequent enough to be feasible for a trial. These three definitions also performed well at predicting the likelihood of growth faltering. An important observation is that all three definitions include diarrhea duration, which indicates that diarrhea duration is an important component in any eventual diarrhea severity definition. In a sensitivity analysis, we observed that these three definitions and also GEMS had relatively high sensitivity for predicting death or hospitalization. In general, severity definitions had good performance for predicting relevant adverse events. However, we recommend choosing a definition that includes the diarrhea duration and dysentery. Actually, dysentery is associated with the Shigella infection. And choice should also consider practical factors. For example, simpler definition may facilitate easier data collection, and complex definitions may allow more disaggregation and secondary analysis. I will stop it here, and I will hand over to the next presenter. Thank you all.
Yeah, thank you so much, Farhana. My name's Billy Ogwell, and I'll be giving the last talk of our webinar today. We'll pivot a bit to the costing component of the EFGH study, and this presentation will be on the costs and cost drivers of Shigella diarrhea and their implications for cost savings from Shigella vaccines. So to an overview of the methods. Our main outcome was the mean cost per episode of Shigella medically attended diarrhea. And for this outcome, we included Shigella positive cases by either culture or by molecular methods, which have been described previously. And also we report this from the societal perspective and therefore include costs incurred by both households and the health system. Yeah, so to data collection for direct medical costs, diarrhea-specific drugs and diagnostic costs were obtained from the study CRFs and the national drug price lists for each country, while the health service delivery costs were obtained from the study CRFs and the WHO choice database. Direct non-medical costs, including transport and accommodation costs for caregiver and visitors, were obtained from the study CRFs, and indirect costs covering time lost by caregivers from work were obtained from the study CRFs and the ILO database. So to some results, here we present the mean cost per episode of medically attended Shigella diarrhea, and the dark green color shows the health system costs, while the light green color shows the caregiver costs. On average, Shigella MAD episode was $9.63. However, there were variation across sites, and this was lowest in Pakistan at $4.4 and highest in Peru at $16.61. We also see a wide variability in the caregiver costs across countries that had similar health system costs, such as Bangladesh, Kenya, Malawi, and Pakistan. So here we present reasons for the variations that we are seeing across sites, and this was largely threefold. So the first source of variation was drug costs, and this was based on drug usage and the national drug price list. And from more analysis, we see that this was highest in Mali, followed by Peru. And the second point of variation was the service delivery fees, which were estimated based on the WHO choice database. And these were highest in Peru, followed by the Gambia. And the last source of variation was the caregiver opportunity costs that varied based on the time lost from work and wages, and these were highest in Malawi, followed by Kenya. So we further stratified the episode costs by the visit characteristics, and we see that on average, inpatient costs are $35 higher than outpatient visits. This could be attributable to high treatment costs for inpatient visits, hotel costs, as well as time lost from work, We also see wide confidence intervals for the inpatient estimates, and this could be as a result of variation in the length of hospitalization. We also see that tertiary visits to tertiary level hospitals are in general more expensive, and this could be because they're handling more severe cases or inpatient cases. And lastly, we see that severity costs increased by severity across all definitions, and here we present estimates for the modified Vesicari score, and we see that mild episodes were on average $8. Via diarrhea cost about $14 on average. We further ran a regression analysis to estimate the effect of visit characteristics on costs. And for this, we ran a generalized linear model using a gamma distribution with a log link. And we used that because generally costing data are right skewed. So after adjusting for child age and site, we found that higher costs were associated with diarrhea severity. And for example, if we look at the estimates for modified Vesicari score, we see that compared to Shigella MAD episodes, which were mild, costs for moderate Shigella episodes were 31% higher, and severe episodes were 88% higher. We also see that higher costs were associated with dehydration and wasting, and more specifically for dehydration compared to Shigella cases with no dehydration. Cases that had some dehydration, the cost for cases with some dehydration were 1.6 times higher, while costs for severe episodes were 2.7 times higher. While for wasting, compared to Shigella cases that did not have wasting, costs for moderate wasting was 19% higher, and those for severe wasting were 56% higher. So we also estimated the annual population level costs of Shigella MAD episodes, and this was defined as the total estimated costs of all child Shigella MAD episodes per 100,000 population per year. And we report this from the societal perspective, and this was highest in Mali at $17,363 per year, and lowest in Pakistan at $2,163. We observe wide variability in the population costs across sites, and this is due to differences in the estimated number of child Shigella cases per year, as well as the costs per episode. So we also conducted scenario analysis to estimate the impact of Shigella vaccines and various assumptions. And this decision tree presents the scenarios that we looked at, and the assumptions were largely around vaccine serotype targets, the number of doses, as well as the level of diarrhea severity, and also the age of vaccination. So from our scenario analysis, we see that Shigella vaccines could avert up to 34% of Shigella MAD costs per year at the population level. And we also see that starting vaccines early will have a big impact. And this can be seen from scenarios A and C, which are scheduled at 6 and 9 months, which resulted in higher proportion of costs averted compared to scenarios B and D, which are scheduled at 9 and 12 months. So in conclusion, the average cost of a Shigella MAD episode was $9.63, but varied across sites, ranging from $4.4 to $16.61. Variation in treatment costs are expected due to different markets and health systems. The annual population level economic burden of Shigella varied even more widely due to differences in treatment costs, age distribution, and Shigella incidence across settings. And in 5 out of 7 country sites, households shouldered majority of the costs. And this is true even in a setting where medical costs are primarily covered by the health system. Households still face transportation costs, lost income, and co-pays. We also saw that the cost of Shigella MAD episodes compared to other diarrheal causing pathogens are quite similar. And our data highlights opportunities to reduce Shigella treatment costs, and this can be achieved by one, preventing severe diarrhea cases prior to the onset of dehydration and hospital admission. And finally, early modeling suggests potential Shigella vaccines would avert up to a third of the population level cost of Shigella MAD per year. I'll hand it over to Patty, who will give us an overview of the results and the next steps.
Thank you so much, Billy. And thank you to all of our wonderful presenters today. It's such a privilege to be able to share this data with our audience. So I am just going to quickly talk about our next steps in EFGH and the context of EFGH, and then we'll take questions. As I mentioned in the chat, to help us stay organized with the questions, please do type your questions in the Q&A box rather than the Zoom chat, and we'll use that to kind of organize our question and answer session. So we have recently submitted the primary results from EFGH to peer-reviewed journals, and preprints for 4 out of 5 of those manuscripts. The 5th will be coming soon, are available using these QR codes, and we'll also try to paste these preprints in the chat. And, I think overall, as hopefully we've convinced the audience, we feel that EFGH has really confirmed what most in the field have long known, which is that Shigella continues to be devastatingly common among young children in many low-resource settings, and with its growing AMR, its links to poor growth and high cost, make it all the more urgent to prevent with vaccines. Several vaccines are in the pipeline. I know we received a couple of questions about the status of the vaccines. There is a bivalent vaccine in a phase 3 trial now, and several quantivalent vaccines in phase 2. WHO is very much supporting Shigella vaccine efforts by providing strategic guidance to advance product development, testing, and eventual adoption. In 2024, WHO convened regulators, vaccine manufacturers, and policymakers across national, regional, and global levels to discuss the optimal phase 3 vaccine study design. EFGH data has been a rich resource for these conversations, and will continue to be leveraged for decisions around clinical endpoint definitions and optimal microbiologic confirmation methods. EFGH has just started its 3rd phase, which goes through 2027. And first, we are, of course, doing widespread dissemination, including in community, national, regional, and international platforms, such as the webinar today. We are also leveraging this rich EFGH data set for additional scientific questions that can be answered in the pediatric enterics field. And finally, we are conducting implementation science research to really understand policymaker preferences for future Shigella vaccines, and identifying relative priorities and trade-offs regarding vaccine attributes and delivery methods. Finally, we'd be remiss not to mention that the first Shigella-specific conference is being held at the Institut Pasteur in April of 2026. This conference will feature a lot of the EFGH data, some of which you saw today, some of which we haven't yet shared, and will be a wonderful opportunity for community building in our field. Before we head into questions, I first want to acknowledge the efforts of hundreds, probably actually thousands of people who are involved in the EFGH study and consortium around the globe, without which today's webinar would have not be possible. And most importantly, on behalf of our consortium, I'd like to express our sincerest gratitude to the EFGH participants, their families, and communities. Okay, we will now open the floor for questions, and we'll do our best to answer the questions that have been raised in the Q&A box. We have tried to, if there were related questions, we've tried to kind of synthesize them. And we're going to start, we saw a lot of questions around AMR. So we are going to start with a question about somebody noting extensive regional differences and even country-specific differences in antimicrobial resistance patterns in Shigella isolates across the EFGH sites, and asking if we had some, speculation as to what is leading to these regional differences. Maybe I can start with Henry if you want to add some of your thoughts to that question.
Yeah, so our speculations for these regional specific resistance differences that were observed, this could be driven by several factors, including differences in antibiotic routes, types and frequency of antibiotics used both in the community and in healthcare settings, as well as overuse of antibiotics, patient control practices, low public awareness, of course, as well as the disease burden and treatment with antibiotics, and a lack of sanitation, which could give more opportunity for AMR team share and transfer.
Thank you so much, Henry. Would any of our other panelists like to comment on this question?
Yeah, hi everyone. So if I just share the experience from Pakistan side, so now what we are observing that due to easy access to these antibiotics, people can or even the physician, they are using these antibiotics such as in common illnesses, even viral URTI. So I'm just worried now because we have seen lots of resistance pattern in quinolones like ciprofloxacin, but overuse of azithromycin in our setup is like very concerning that we may eventually develop azithro resistance more in Pakistan.
Thank you so much, Sonia. Okay, kind of related questions we had were around overprescription of antibiotics. How did we manage antibiotic use in EFGH? And as a field in the Shigella space, how do we all think about antibiotic use for Shigella? Maybe I can add a couple of my thoughts, and then one of the panelists can also chime in. So, as Henry and Sonia mentioned, of course, overuse of antibiotics we think of as being a cause, availability without prescription. But, as Henry pointed out, I think a lot of studies have importantly shown the importance of sanitation, antibiotic gene sharing in contaminated environments can really exacerbate resistance. And we know, and it continues to be shown, that vaccines and prevention of infectious diseases really can combat antimicrobial resistance because of it reduces overall antibiotic use. So in EFGH, we really spent a lot of time in the beginning looking through all the WHO guidelines on management of diarrhea. As everybody knows, there's no point of care diagnostic that is being used at these sites for Shigella. So we rely on syndromic management following WHO guidelines, which is really only to treat dysentery. So we followed those guidelines. And however, we did have culture data available within about 3 to 5 days and changed the course of treatment if upon contact found from the caregiver that the child was not doing well and indeed did not get the appropriate antibiotic. So we kind of went above and beyond in EFGH, the standard of care. But we did still see these really important consequences of Shigella. There was so much regional variability. We see ciprofloxacin resistance really being the biggest problem in South Asia, less so in some of the African sites. I think site-specific susceptibility data is really so critical that we can't just infer resistance from Bangladesh and apply it to resistance patterns in Kenya. I think we really highlighted that here in EFGH, and we all really strongly believe in the importance of continued surveillance of AMR so clinicians can really use local susceptibility data to inform their decisions. And while WHO guidelines all really importantly name that, the practicalities of making that available is quite difficult. So I know there's efforts hopefully in antibiotic development. I know at ICDDRB, they are working on a process to review susceptibility and make recommendations based on updated susceptibility patterns, and use pivmeselinum a lot, which we showed had pretty high susceptibility across the sites, but is not often available. I wonder, Farhana, specifically around the pivmeselinum, that if you could talk a little bit about the ICDDR experience of using pivmeselinum and the challenges despite its susceptibility.
Thanks, Patty. Actually, in ICDDRB, the recommendation is to give the pivmeselinum, but the challenge to recommend this antibiotic is actually the process of preparation of the antibiotics is little bit difficult. And we have experienced the difficulties during the process of antibiotics because there is a certain amount of diluent that we have to mix with the powder of the antibiotics. So and the dose is very specific. You have to describe. You have to explain the dose to the parents, and we sometimes found difficulties in explaining. And sometimes we have observed that the parents actually could not understand the process, and sometimes they failed to give the antibiotics properly. So, but our effort was to provide the antibiotics properly. So, our field staff always tried to contact with them, and also sometimes our staff also visited home so that they don't miss the antibiotic dose at a particular time and at a proper dose, so that the proper dose has been given to the participant. But Patty, as you mentioned, ICDDRB is trying to develop a guideline for the antibiotics. But ICDDRB is not the only hospital where diarrhea patients are admitted. And I should mention that in EFGH, we have enrolled participants in different hospitals other than our field office and other than our ICDDRB Dhaka hospital. And we found that clinicians, they all prescribe antibiotics whenever comes with diarrhea, especially for the children. And another observation I should mention that sometimes parents don't like if we don't give any antibiotics to them. So sometimes it is difficult to convince them with only ORS or only IV saline. Thank you.
Thank you so much, Farhana. Maybe we can link this to a question in the chat around Shigella leading to bacteremia and blood culture of Shigella, the clinical management of which would even be more critical. I know, Jen, you are involved in blood culture surveillance. Do you want to comment on this or the AMR?
Yeah, so I can comment on the blood culture. Obviously, Shigella bloodstream infection is severe, but it is relatively rare. So I think WHO figures suggest that it happens about 0.5% to about 7% of shigellosis cases will lead to bloodstream infection. Obviously, those figures are quite broad depending on where in the world and the kind of studies that produce them. But we do have very robust longitudinal blood culture surveillance data from Queen Elizabeth Central Hospital in southern Malawi, which is a rarity in the region. And we've recently done an analysis of that, and we know of over 200,000 blood cultures taken, only 40 were positive for Shigella. So severe, but perhaps not of massive clinical importance in this setting. Over.
Thank you so much. Maybe I can hand it over to Adama. If from the Mali perspective, what you're thinking about or what your challenges are related to clinical management of Shigella. And I'll also bring the question to you that was raised in the chat about the audience is kind of surprised by the high rotavirus prevalence that we observed that you showed in your slide. So clinical management of Shigella, what antibiotics you're using in Mali, and then rotavirus.
Yeah, thank you, Patsy. I think I may start with the vaccine, the high burden of rotavirus. So the explanation is quite simple. We have in Bangladesh the rotavirus vaccine is not yet introduced into the API schedule. So that's maybe the explanation why we have this high burden of rotavirus in our study. So regarding the antibiotics, so in Mali, I think there is a need to increase awareness, clinician awareness about this issue. So the guidelines are not quite follow, and there is a misuse. People, as you may notice, prescribe a lot of sex reduction at certain level, but also in the SESCOM level, you will see cotrimoxazole systematically prescribed for any kind of diarrhea. This is really explaining why we have this high resistance observed in Mali and all over sites. So really there is a need to increase awareness for the clinician, but also the general population. Sonia mentioned the environment issue. So for some clinicians, when they see that the environment is not good, systematically they prescribe antibiotic. Regardless the diagnostic test, they will prescribe antibiotic. So this is something to consider a lot. Thank you.
Thank you so much, Adama. Just trying to keep track of the questions. Okay, so somebody in the audience noticed, and we agree, there's quite a lot of serotype variability across sites. And, I think this has, of course, implications for eventual vaccines. Did we want to basically comment on that? Maybe Francesca, I could have you start and I can add anything that comes up.
Sure. So by culture, the leading subserotypes were flexneri 2A, 6, 4A, and 3A. This matched by culture. Yet by culture, we also see 1B and being dominant. The leading quadrivalent vaccines currently contain Soniae and Flexneri 2A, 3A, and 6 on one side, and then Soniae, Flexneri 1B, 2A, and 3A on the other side, on the second vaccine in the pipeline. So considering this and our results, one of our quadrivalent vaccines would achieve about 64% coverage, and the other one 58% by culture. If we consider cross-protection, this could increase up to 75%. And yes, there is site variation in the leading subserotypes. Patty, do you want to add anything else?
No, I think you covered it. Thanks. Okay, there was a question about the costing data and kind of plans for cost effectiveness. Billy, do you want to comment on anything around costs and our plans to do cost effectiveness analyses? If so, there's a good question about cost effectiveness. We recognize this is critical to policymaker decision making as policymakers continue to get inundated with new vaccines, new interventions, and have a lessening budget, especially in these times. So the costing data that we have in EFGH will inform in our phase C, hopefully a cost effectiveness analysis. Of course, we don't yet have efficacy data from vaccines, but of course we can project them and use various scenarios. And so we will be working on that in this next phase of EFGH as we move into this lens of really trying to understand what policymakers want and need related to Shigella vaccines. So I think with that, we will take a final question, which is, I think just a question about phase 3 trial sample sizes. I think that's a critical question, particularly when we showed you all differences in incidence and prevalence between the two microbiologic confirmation methods, culture and PCR, which, depending on which is used in the eventual trial, really impacts the trial sample size calculation. Liz Rogowski, who's a part of EFGH, has published some sample size calculations using GEMS data, and we can put that study in the chat. And the plan will be to update those estimates with EFGH incidence data, but the EFGH incidence data, fortunately or unfortunately, is quite consistent with previous studies in terms of burden of Shigella. So we don't anticipate sample size estimates will change that much with this data. The sample size range from about 10,000, 3,000 to 30,000 kids, really depending on where it's conducted, what's the microbiologic method, and what's the clinical endpoint definition and the duration of follow-up. So with that, I want to conclude today. Again, a huge thank you to our panelists, to all of the EFGH team members, and to our audience today, who we feel a strong partnership with. Collectively, I know we are all committed to moving the Shigella field forward and really moving towards a vaccine to prevent this disease, particularly in children. Thank you all for being here, and we look forward to continuing these conversations with you in the future. Bye-bye.